Okay, welcome again. Let's get started. We still have individuals logging in, so this recording is actually this webinar is actually being recorded. If you happen to miss certain segments or want to refer back to the webinar, the event will be posted on the TTA help desk probably within the next 2 to 3 days, along with any materials that's demonstrated and shown here today in terms of the slide deck. Again, I'm Jamie Edwards. I'm director of the TTA Center, and we certainly want to welcome you to today's event. Again, the Monday after Thanksgiving. We certainly hope everybody had a good holiday. Just a few items again. Upon login, since this webinar is extremely large, all attendees have been muted in advance. If you would like to pose a question, let's use the text box within your GoToWebinar control panel. You will see the small call out box. You can certainly type in any questions there. We, Melinda and I, along with Bill, will be tracking those questions posted, and we'll have natural stopping points to address questions throughout the presentation. I'm certainly honored to present, to provide the opportunity for each of you to hear from Melinda Pancratz. Many of you know Melinda from Wake Forest University School of Medicine, and who serves as the lead evaluator for our state block grant efforts. Melinda will be jumping in the presentation a little bit later into the event. To kick us off will be Dr. Bill Gary, who's founder of Global Evaluation Solutions and has 20 years of evaluation, organizational consulting, and community level prevention experience. He works with local, public, and private prevention and treatment service delivery organizations, state level prevention agencies and organizations, and a variety of community-based health and violence prevention initiatives throughout the United States. Dr. Gary's previous experience includes acting as Deputy Director of Evaluation and Research at the National Coalition Institute, a Master Trainer with the Community Anti-Drug Coalitions of America, a trainer and consultant with or for Communities That Care, and a coalition coordinator for both suburban and urban prevention initiatives. He's also an experienced grant reviewer for the National Institute of Justice, the Substance Abuse Mental Health Services Administration, SAMHSA, Office of Juvenile Justice and Delinquency Prevention, and the Office of Minority Health. Dr. Gary is also a visiting assistant professor of sociology and criminal justice at LaSalle University in Philadelphia. So, Regan, I'll give it to you to get started.
Okay. I'm hoping everybody can hear me. Can you guys? Yeah, okay. So hi, everybody. Good morning. And I certainly hope you had a good Thanksgiving break. I know it always seems to go by too quickly for me. Welcome. I wanted to just walk you through kind of some information, background information on effectiveness in prevention. Some of this you've probably heard before, or you may have heard in different contexts. But let's start by going through the agenda. I think we've already started with the introductions and talking about why we're here is to kind of kick off a set of trainings that are going to occur over the course of the spring and helping all of you with your community assessments and hopefully with your planning processes after that. And we're going to talk a little bit about kind of the when, the where, the what of prevention. This is where some of this will be familiar to you. We're going to talk about some of the research that talks about what is effective prevention, and we're going to focus primarily on two general ideas. One of them is comprehensiveness, which many of you have probably heard before, and the other one is alignment, which some of you probably have heard before. And then we're going to cover some of the logistics. Melinda's going to cover some of the logistics on the needs assessment and strategic planning process. And certainly if you have any questions as I'm going through this, I know that Jamie said that he'd be tracking the chat window or the question window, and we're going to take a couple of breaks just to catch up on any questions that may occur, but please feel free to jot them down and send us a note, because we are going to be tracking those, and we certainly want to be able to address any questions that you have. Okay, so let's talk a little bit about the why are we here, and we're here primarily to help with the data collection process. This is an issue that most providers or community groups have to deal with. That is, how much data do I collect? What kinds of data do I collect? How much of it do I need? And the hope is, by showing you what effective prevention is, that will help with the risk prioritization process, making sure that you're just gathering the data that you actually will need and the data that you will actually use to track your effectiveness as you go through. I know that in my experience in doing this, I've seen a lot of organizations, not just community organizations, but police, education, they tend to gather more data at the beginning than they actually need. So our hope is to try to make that process a little more focused. So this is a general model of where we're going to go today, and this is where some of, you've probably already recognized some of these terms, but since my dad was an investigative journalist, he always taught us the 5 W's and the H for how, who, what, when, where, how, why. And so I thought it might be a good idea to frame what works in prevention under that kind of model. So I apologize if it doesn't strike a chord with everybody, but this seems to be, I think, the best way to do it. Now, you're also going to notice that I'm going to use some models that you're probably familiar with. Those models are basically just teaching tools for me. They are ways of trying to, I guess, associate an image with a concept, right? So how do we do that? So we're going to talk about the when of prevention. We're going to talk about who prevention who's the focus of prevention. We're going to talk about what we should be doing under intervention types. We're going to talk about where intervention works, and we're going to talk about how we do it, which is where the mutually reinforcing, and we'll have a conversation about alignment. So this is something, this is probably something everybody's probably familiar with, right? I use this in a ton of different presentations, and it's the one I'm sure you've all seen before. I know the language for North Carolina also describes universal, selective, and indicated under prevention. But this really talks about the when, right, of prevention. And the when of prevention is in the blue. And I feel the need to at least address that in part because sometimes I think there is confusion and maybe even a lack of clarity about what prevention actually is. So once a case gets identified, of course, that's the beginning of the treatment process. So prevention is really everything that happens before there is some type of specific case identification. And those definitions you're probably familiar with. We're not going to go into great detail, but for those who aren't, I like to make sure everybody's on the same page. So when we talk about universal preventions, we're not talking about specific groups, right? We're talking about everyone in a community. It's not directed at anybody in particular. When we talk about selective, then we can have people who are maybe higher than average risk, in this case for substance abuse. And these folks are identified because they find themselves often in social contexts that place them at higher risk, even though there is no specific indication that any one person is actually a higher risk than another person within that group, right? So selected interventions probably is something that you're very familiar with, because when we talk about, for example, underage drinking, youth are a selected group, right? Because they are underage, and technically by law they're the only people who can underage drink. So they are selected. The indicated, as I mentioned before, is people within that group who have already engaged in other high-risk behaviors. So maybe they've not engaged in substance abuse, but they have engaged in behaviors that are highly correlated with substance abuse. And we can have prevention activities that focus on any of those or any combination of those and still fall under the umbrella of prevention. Okay. And as I said, if there are any questions, please feel free to jot them down. Okay, so from there then, whoops, there we go, comes the question of who gets prevention. And when we talk about universal prevention, and this is again language that you use, I think, with the direct and the indirect. Direct is serving an identifiable group of participants, but who have not been identified on the basis of individual risk, whereas indirect is supporting population-based programs on environmental strategies. So again, if you're involved in youth substance use, for example, probably you're doing a lot of indirect stuff for prevention. And we'll also talk a little bit about the different kinds of prevention that fall under each of these, right? So we can have different kinds of prevention that impact these people in different ways. So we've either identified people or we have not identified them in terms of a specific population. Where prevention occurs then is where we start to see alignment. Some of you have probably seen this. This is just a basic social ecology model. There's a lot of different versions of this out there, but primarily I focused on the one that is focused on by the CDC when they do their violence prevention. And really it's talking about where prevention occurs, because the thinking is that there are risk factors, term you're familiar with, right? In each one of these were called domains, right? That individuals have certain risk factors that are associated with them, and then within the family unit there are risk factors, peers of course, then school, community, and society. And what we see typically in prevention is that these are layered in the way that they are demonstrated here on the slide, in that they all impact each other, right? So broad level, for example, community norms and behaviors will impact the behaviors and norms in the school, which will impact the norms and behaviors of peers, which will impact the norms and behavior of family, all the way down to individuals. So these all interrelate. And when we're thinking about what works in prevention, as we'll see, it's important to think about a couple of things with domain. One is, how important are the risk factors in that domain? The other is, what kind of access do we have in that domain? So for example, early prevention in the late 1950s, early 1960s that started in San Francisco, they focused initially at the family level and kept expanding out, and it kept getting bigger and bigger until they finally got to the society level, and kind of they hit a wall there, right? Because there wasn't a lot that they could do about some of the risk factors that were occurring at the national level, right? So it's important to think about where can we have influence, and how can we influence different domains in a way that provides consistency. So again, thinking about how these interrelate, and those of you who do treatment, for example, are very familiar, I'm sure, with the idea that you can have somebody come in as an individual and put them through some type of cognitive behavioral therapy or whatever, but if they go out into the same neighborhood and they have the same cues for their addiction, then that becomes very challenging, right? So we can impact people at certain levels, but if that is not supported at other levels, that can have a kind of a negative impact on what we're trying to do. So part of this then is thinking about how much influence we can have at what levels that we can have them, and how can we try to get different levels to reinforce each other. And again, if there are questions, please let us know. So let me just stop before we start talking about this one a little bit and check in with Jamie, and I don't have my window up. So are there any questions right now, Jamie?
We don't have any questions currently.
Okay, so that means everybody is either completely on board or they're asleep. So, which is fine, either way, live TV. So this should be familiar to everybody, right? In terms of what are the intervention types? And again, some of you are very versed and very skilled in these, others less so. So if you're very versed, please bear with me. I want to make sure everybody's on the same page again. And we start with community-based processes, right? Which basically focus on providing substance abuse prevention services in a community. And what does that look like? So that there is access and so that there are prevention messages that are easily, readily available at the community level. From there, then, the second tier talks about, the second type talks about environmental strategies, which we can engage in. This one may deserve maybe an asterisk next to it, as well as community-based process, because when we talk about changing community standards, codes, and attitudes, this is where we find we really get a lot of traction in the research on prevention. Obviously, one of the most effective ways of impacting any behavior is through law change, whether that law is formal, informal, but formal, of course, is the better way to go. And I always like to use examples from the real world, right? Which, if we look at tobacco use, for example, we gained a lot of leverage and a lot of traction once we started passing laws about clean air laws for indoor clean air, and all that definitely had a demonstrable effect on people's behavior when it came to smoking, and it still does. It still does. So environmental strategies then, along with community-based processes, are both critically important. We also, of course, talk about prevention education, providing information activities aimed to affect critical life social skills, decision-making, all of that. How do people manage messages that conflict with health, right, or conflict with prevention, whether it's substance abuse, as we're talking about, or violence prevention, whatever it is? There are always going to be messages, there are always going to be social situations out there that make it difficult, or else we wouldn't have to have prevention, right? So it's thinking about what kind of information can we provide to people to help them make better choices. Along with that, and it kind of overlaps a little bit, is the information dissemination piece. We find that often providing information is an important cue for people to follow. It is something that allows people who want to make change to kind of grab hold of, because they now have information on why they should make that change and what the potential benefit is to making that change. So information dissemination is very important. Problem ID and referral is the second to last one down the bottom. And this is where we're thinking about who are people that are already engaged in the behavior at some level, and how do we try to identify who they are and what needs they may have that could reverse their initial trend in heading down that road, right? So what are the things that we could provide for them that will help offset this potential for addiction that they may be facing? And then, of course, alternative activities is basically thinking about, are there ways that we can shape either at any level, family events, community events, school events, that will focus on certain populations and provide them with activities that hopefully reinforce healthy lifestyles, that will reinforce the ideas of prevention that we're trying to promote maybe through our dissemination campaigns, or maybe through our prevention education, right? So again, it's thinking about the way that all 6 of these interact with each other, and are we engaging our communities in ways that are consistent across all of these. And so when we talk about intervention types, what's most important here is a variety and consistency, right, of these. Okay, so when we talk
then about— Can I just add in one thing real quick?
Sure, please do.
I also wanted to add in North Carolina, of course, many of our providers know that the first 3 strategies listed of community-based process, environmental strategies, and prevention education are core strategies for North Carolina, and the other strategies of information dissemination, alternative activities, and problem ID and referral are considered support strategies for those core strategies.
Yes, and that's a great point, and there's a reason for that, right? So Melinda, thank you for pointing that out. And I'm always, I don't get to see everybody face to face, and I don't want people thinking that, I'm an ivory tower kind of guy, because I definitely am not. But what we know from the research, and certainly from my experience, is that those core, the environmental strategies, prevention, education, community-based processes, are really the most important ones, right? They're the ones that gain the most traction, which is to say, if I only had the resources to do one of these 6 things, in terms of prevention, right? In terms of thinking about prevention, obviously we need problem ID and referral, but when we're thinking about prevention, it would definitely be one of these 3, focusing on environmental strategies, communities process, and prevention education. This is where the prevention research indicates we really get the most traction. So yes, thank you for pointing that out. And what
Bill, I do have a relevant question.
Sure.
Could we have a good example of community-based process?
Sure, let me go back. Sure, so when we think about community-based processes, I think, at least in my experience, I do a lot of work with inner city providers and coalitions. And so one of the things that they're constantly talking about is talking about the kinds of substance abuse prevention services that are available in those inner city communities. And when we talk about substance abuse prevention services, we are talking often about other types of activities. We could be talking about treatment there, like the availability of treatment, and not just in terms of the number of them, but in terms of people's access to things that encourage substance abuse prevention. So at least from my experience, and Melinda can talk about this maybe since she's been dealing with a lot of coalitions down your way a lot, when we're talking about inner city, we just want to make sure that people have access to the other kinds of prevention services that they need to have, and primarily it's that. So those, often we find that there are services available, but people may not know about them, and usually that's the biggest challenge for community-based process. Melinda, did you want to add anything to that?
Yeah, I was going to say that a lot of the work in North Carolina under community-based process does fall under the work that we do within coalitions that help connect the various agencies. Some of that is also the needs assessment work that we do, as well as the planning, where we're really working collaboratively together across a variety of different sectors to really be thinking more strategically and holistically about what we're doing and why we're doing it in prevention. Some other types of things that we do in North Carolina for community-based process is some do things like town halls to engage the community in helping determine priorities for the community, as well as to learn about what the problems are. A few people do some other community building things, but coalition work, our strategic planning and our needs assessment would be the primary things that we're really doing in North Carolina. Some people are also doing models like communities mobilizing for, what is, on alcohol. I'm spacing on their full name, but which falls partly under community-based process and partly under environmental strategies for what they choose to do for intervention, but that kind of more community diagnostic process falls under community-based process.
Great.
Communities mobilizing for change on alcohol is the full name of the intervention.
Right. Okay, great. I hope that helps. And from that explanation, then I'm hoping that people can see that it, and this takes us to kind of the next part of the conversation, right? Is when we talk about alignment, it's very difficult to engage effectively environmental strategies if you're not engaging in a community-based process, right? Because those changes need to be community level. You have to have the right people at the table. You have to be sharing information in order to get to environmental strategies, even with prevention education. So, I think, and this is part of what we're going to talk about more elaborately in the trainings themselves. I mean, when they come up in the spring, one of the things that I hope that everybody's aware of is, as a provider or as a coalition, you're probably already involved in all 6 of these, but you may be more informally involved in some of these and more formally involved. In other words, it's my experience that people have the tendency to focus on certain one of these, but that doesn't mean you're not doing them. And so what I would say is it's important to be able to understand what it is that you are specifically doing when you're doing an assessment. And again, we'll get more into this later, but when you're doing an assessment, it's important to know what you're doing in all 6 of these, even if you don't think you're doing much, because the goal here, as we talk about alignment, is, again, making sure that we're not doing anything that is contradictory in one area to what we're doing in another area, right? So if we, for example, are not very concerned about our community-based process, but we're very concerned in environmental strategies, it's possible, because we're not really tracking our community-based process very well, that we actually might be engaged in behaviors that are making our environmental strategies more difficult to accomplish, right? Because we're not being cognizant or mindful about the other things that we're engaged in. And that's what alignment refers to, right? When we talk about mutually reinforcing, supporting and coordinating at each level, so that we want to make sure that our community-based process is directly coordinating with our environmental strategies, is coordinating with our prevention education, is coordinating with alternative activities. And that's also true if we look at prevention through the lens of, say, a social ecology model, which talks about where are we doing it. And I mentioned that earlier, right? We want to make sure that what we're doing with individuals, for example, is not contradictory to what we're trying to provide for families, peers, and schools. We want to make sure that it's the same kind of messaging that is consistent. And that's really where the challenge, I think, of good prevention comes in a way, because, inconsistent messaging is something that can lead to unhealthy behaviors, not as dramatically as direct messaging about unhealthy behaviors, but certainly when people are confused about what is a healthy behavior and what isn't, that opens up the door for more engagement in unhealthy behaviors. So the challenge with prevention is making sure that not only are we providing consistent messaging, but that we are supporting and coordinating it at each level. Because if we have gaps, that then leaves possibilities for people straying and engaging behaviors that we are trying to prevent, right? So I hope that doesn't go too far down the road and, Melinda, tackle me if you have to, but that's probably going a little too, might be going too far down systems planning, but those are the kinds of things that I think are important to have conversations about, right? So then the very concept, so this is what mutually reinforcing is. Each part, no matter which model you're looking at, each part is reinforcing or coordinating with others. And then the alignment part then is the focus on the behavior. Yeah, Melinda.
I was just thinking another good point to make related to that mutually reinforcing, that is in prevention, we, unfortunately don't have Bill Gates' fortunes, for example. So we very often have to limit what we're talking about. So I wonder if you might talk about how the importance of doing, addressing one issue really well in that mutually reinforcing issue versus trying to address all the problems in your community.
Yeah, and that's a really good point. And there's a lot of systems research out there on prevention, and I think one of the more interesting elements to that is if we look at treatment, for example, the sources of money and resources for treatment are varied. They come from state entities, but they also come from not-for-profits. They come from individual donors, will donate money. We don't see a lot of that in prevention. When we look at how resources are drawn into a complete model of prevention and treatment, if we go back to the IOM compass again at the beginning, what we find is that prevention is almost completely reliant on government funds. And you're exactly right, Linda. The issue that then you're faced with if you are a prevention organization is you don't have the resource versatility, which is why it becomes so critically important in prevention to make sure that you are bringing the right partners to the table and that those partners are actually offering something that can be used. And so in a way, from an organizational standpoint, we can certainly talk about this when it comes to early stages of kind of assessing how your organization is functioning, which I think is a really important thing to look at. It's not just having a lot of partners. There's a lot of not-for-profits. I do a lot of work for not-for-profits, and they get a lot of money from people who just have a general interest in the topic or in the treatment program, and they just want to provide support for that. And so what they do is they then leave it up to the organization to decide how that money is going to be disseminated. Prevention has a kind of a slightly different limitation from that, right? Is that you don't get a lot of people or not a lot of companies that are going to donate a lot of money just to the overall idea of prevention. And so, unfortunately, part of that then is making sure that our partners are stepping up and coordinating with what it is that we're trying to do, right? And so, yeah, so part of this assessment process, and some of you, if you've already gone through the assessment process the last time we went through it, you're familiar with this, right? Like one of the things you're supposed to do is you're supposed to assess your organizational capacity, for example, to address, and so yes, you can't do everything because your resources are pretty limited. And so it's thinking about not just the consequences of the problem that's being engaged in, but it's thinking about where you can have the most impact. And so sometimes, and I've seen this a lot, I've been over 20 years of doing this, I've seen coalitions who think that they've identified the problem, but don't have the organizational capacity to interject at what they consider to be the leverage point. And so if you then have two decisions. One, we're going to go ahead and put our resources into this and keep our fingers crossed and hope that eventually we can have an impact. Those efforts usually don't get as far as organizations who look realistically at where they are and say, yes, this may be the leverage point that we're trying to get at. Say we're talking about, vendors or whatever, talking about just the number of, this is certainly something in the inner city areas in particular, but just the number of distributors that are available within like a 3-block radius of where you live. Maybe as a group, we don't have enough influence to do anything about that right now, but we know that that's where the real push is. So what we need to do strategically is assess where we are, assess where we want to go, and try to figure out where is our foot in the door. How can we eventually get to a point where we can have an impact in the place that the data shows us we really need to have an impact, because maybe we can't do that now. So I always believe, and Melinda, I think you were probably alluding to this in the question that you asked, I always believe in starting smaller and getting bigger. My experience particularly in violence and substance abuse prevention is that is a longer term approach, but is always in the end more effective than trying to bite off more than you can chew, because that's when you start getting a lot of negativity in the community, and there are people, you have volunteer issues because people are frustrated because they don't see changes. It's always better to start where you are and then work up from there. And what I'm hoping is, one of the things that we're going to talk about in the trainings in the spring is, when you're collecting data, for example, for assessment, it is important to think about where you want to be. And I know that sometimes providers and coalitions and not-for-profits, sometimes they don't think that through as well as they could, that the needs assessment is viewed as a separate process from the actual delivery of prevention in the community. And that's where you start running into issues where you may be putting a lot of resources into an area that you may not have a lot of impact. So it's important to know where we have an impact. And I can't remember the name of the author, but he talks about, at an individual level, he talks about spheres of influence, and I think that organizations need to keep that in mind as well. Does that address what we're talking to, Melinda?
Yeah, I was wanted to address the point that very often we can't do everything, so it's really important to be very strategic in what we do choose, so that they do have that kind of mutually reinforcing support by going narrower, but hitting that in a couple of ways.
Yeah, absolutely, absolutely. Okay, so then when we talk about alignment, we are selecting this when, who, where, what. It's not just, and I guess this is where part of the payoff of thinking about all these different models comes from. It's not just thinking about the behavior when you're thinking about strategic planning and you're thinking about how you as an organization can be most effective. It's thinking about all of these other things as well, right? It's thinking about what your sphere of influence is, where your community is, where are the places that your community will allow you to have some kind of influence. And so, what is the general attitude of community leaders about, for example, the difference between direct and indirect, and how do communities look at, say, adult behavior versus youth behavior? It's important to think about all of those things in the planning process. So the alignment then is just part of that planning, and making sure that when you're talking about the when, the who, the where, the what, that you're being consistent and that you are mutually coordinating and reinforcing whatever change it is you're trying to get to, whatever level it happens to be at. And so kind of the reason that I wanted to put all this together was to look at a model such as this, right? I mean, obviously, we already talked about some overlap, right? That it's really difficult to do some interventions without actually engaging in other interventions, right? So it's really difficult to change the law in a community without engaging in some type of community process on how that works, and certainly it's difficult to do it without some type of education process. So when we're thinking about the kind of impact that we want to have, considering the community considerations that we have, I know that's redundant, but think about the context of the community, the community's capacity for change, thinking about our organization, where that organization fits within the rubric of prevention, where it fits within the community, thinking about what are the types of things that are being done, what are the kinds of messages that are being delivered. I think it's important for us to focus in those areas that we gain the most leverage. And when we're doing that, that's why I wanted to show this kind of diagram. Obviously, the center part, right, the one that has the deepest, darkest color, where all the colors intersect, that is where the research says you get the most leverage. At the same time, we live in a real world where having the resources to do all of the, to consider all of those things and to do all of those things at the exact dosage or level that they need to be done is probably impossible. So what we want to think about then is which areas of overlap are we really going to focus on, right? Where do we need most of our resources to go? What kind of strategic planning do we need to engage in so that when we're looking at a Venn diagram, we're thinking about prevention as a three-dimensional image. We want to make sure that we're lining up as much as we can, as opposed to, you know, pretending that we live in a perfect world where we'll be able to do everything, just as Melinda was talking about, and I'm sure just as most of you have experienced, right? You're living in a real world, and it's difficult to know where should this dollar go or where should that dollar go. Hopefully, one of the things that we're going to be able to help with is making those kinds of decisions, or at least having those kinds of conversations at the beginning of the process, which will help determine what's the kind of information that we need in the assessment, so that the assessment plays an active, ongoing role in our strategy, as opposed to the assessment just being another thing that we have to do, and then maybe making decisions that rely too heavily on one area, as opposed to thinking about how we might be able to incorporate these different ideas of when and who, what, where, and having some type of alignment. So I'm going to turn it over to Melinda, who's going to be cueing me on when she wants me to switch the slides. So, so we'll hope that works. And if there are any questions, we can pause for a second and address those. But I think this is the last you'll hear from me on this presentation, I think. So I thank you for your attention. Thanks, Jamie and Melinda, for setting all of this up. And I hope everybody has a safe day. And Jamie, are there any questions I can address now?
No questions currently.
Okay. So there we go. We'll turn it over to Melinda to start talking about the upcoming events and the schedule.
Thank you, Bill. As Bill talked about, we wanted to provide a little bit of foundation on prevention so we can talk about how it's going to influence how we do our needs assessment. So we have been really working to strategize on how to ensure that the training and support that we provide over the next several months really helps you to make this a meaningful and useful process for you and your communities. We know that most of you did not come into this field to be data analysts or collectors. So what we're really going to be focusing on is how understanding how we can get to a really comprehensive, good prevention strategy really draws from the data. We have several things in mind that we're going to talk about in those that's going to help us efficiently collect the right kinds of data and also choose the types of data that are going to be most meaningful to developing that comprehensive prevention strategy. Go ahead. So there's going to be 4 primary parts following today's webinar that we are going to have for the needs assessment series of trainings. The first one is going to be a workshop. It's going to be held both in Raleigh and in Winston-Salem. And you can see the dates for Raleigh are going to be January 23rd and 24th, and that should soon be published. And also it will be held February 18th and 19th in Winston-Salem. And of course, people can choose which section works better for them. We will have a little bit more background at that training on effective prevention, but mostly these are going to be fairly hands-on workshops, and we are going to, we'll have data for you at those. We're going to talk, though, about how you can fill gaps in collecting and prioritizing your consumption and consequence data, and then also in collecting your intervening variable data. And I'll talk more about this in just a moment, but we at Wake Forest will supply part of that data. We'll supply the only required data, and we'll have steps in place where you can decide if you're going to do additional data collection or not. Key in that first workshop is going to really talk about how to prioritize the data that you do have for consumption and consequences, because as we identified earlier, we don't have never-ending budget, so we really have to be strategic. And so we're going to talk about how to really effectively prioritize that data. It's going to focus on just looking at a few key consumption and consequence indicators rather than trying to collect everything but the kitchen sink, to just enough to ensure that you really are capturing the right problems in your community and looking for consistency and showing that those are really great problems. What we're going to do after that, about 2 weeks later, we're going to ask that you submit your prioritized consumption and consequence data, as well as the intervening variable data that you currently have. This is going to be done individually with providers, and it's going to be designed to really try to meet you where you're at and identify if there are ways that you can collect additional data, where you might do that to be most strategically get the most effective data most effectively get that data. The second workshop will be in mid-April, and again, they will be in Raleigh and Winston-Salem. They will be 1 day each, and those are going to be taking the intervening variables that you do have and helping to prioritize those and give some guidance on how you can turn that into a comprehensive prevention strategy. It is important to note that this is the process we're going to provide some advice on. People should continue their current strategic plan as is. And then after that second workshop, we'll also have another midpoint check-in about 2 weeks later. So it's long enough to apply what you learned at that workshop, but not so long that it's kind of forgotten and able to be pushed aside, because we all know we have busy strategies. But at that, we're going to go through your intervening variable prioritization and ask questions to really help you ensure that you've really done an effective job for your community in prioritizing that. And also, we're going to talk about how you can use that for your strategy selection. Go ahead, Bill. The workshops are intended to be, go ahead and go back. The workshops are intended to be very hands-on. We will have some more didactic content, but there'll definitely be some case studies. We'll be having, we'll be applying some of what we do in some interactive activities. And again, at those workshops, the first workshop, we will have the state level data that we have available to you. And so that will be updated consumption and consequence data. As many of you know, we don't have very many statewide resources for intervening variables. And so for that, we will be drawing from the 2017 Youth Prevention Survey. And we'll be developing a few questions for you guys to ask in your communities to check to see, does this still hit the mark for your community? Or if you're in a small community where there was a very large community in your LME, if it hit the mark when that was first done. So if you have additional data, we'll talk about that at the midpoint check-ins. But we'll supply those data there, as well as the questions that you want to ask yourself to make sure for the administrative data and the youth prevention survey, does this data really hit the mark for my communities? Go ahead. There's 3 primary sources that we are going to use to collect data. The first thing that we're going to draw data from is some statewide dashboards we have. Some of you may be familiar already with the public health, alcohol in the public health dashboard, which shows alcohol-related measures for every county in the state. It includes things such as alcohol-related crashes, alcohol-related emergency department visits, subsetted for youth and also for the whole population. It has some suicide, alcohol and suicide data in there, and a few other things that would be very interesting to look at if you haven't already seen that, especially with the increasing emphasis of alcohol with the new Partnership for Success grant. We will also look at the MC Opioid Action Plan data, which a lot of you have looked at, which shows things like opioid-related emergency department visits, deaths. It shows naloxone administration. It has some prescribing data, such as the overall number of opioid pills, high MME prescribing, and co-prescribing of opioids and benzos, which of course are much riskier prescribing. We'll fill in those data sources with a few things from Robert Wood Johnson's County Health Rankings, which have some measures of excessive drinking and a couple other things that help describe communities and that are available at the statewide level. With those, we'll also show every county then, of course, how that compares to the state. And creating some ranks within North Carolina to help you in prioritizing. The second category of data we're going to have is administrative data. The newest source that we haven't had a lot of in the past is North Carolina MC Detect, and that is emergency department data. So from that, I'm very excited. We don't have it yet, but we will have it shortly. But we'll not only have opioid and other prescription drug-related emergency department visits, we'll have alcohol-related emergency department visits. We will also, again, I don't quite know what this data looks like, but it does have codes in it for vaping, as well as marijuana-related emergency department visits. So we'll be able to go a little bit broader into the 4 primary substances that communities are targeting. So I'm very excited about that. We will again have controlled substance reporting system data, which tracks prescriptions. And so we'll be able to have data related to opioids, of course, which you can draw from the North Carolina Opioid Action Plan, but also benzos and stimulants. And then, as many of you guys have used, we'll be able to look at the FDA tobacco inspection data to see the violations for retail tobacco age of sales laws, as well as advertising and labeling laws, which will support your SINAR work. And then at the local level, we will again use the 2017 Youth Prevention Survey. Again, we'll have a few questions just to make sure that really still resonates with your community, since it's a few years later, and also because that's at the LME level rather than the county level. And then it will not be required, but we will help you use it if you have it. We'll have locally collected intervening variable data. Okay, next slide, please. So the midpoint check-ins, this is going to be our way to help meet people where they're at. They'll be done one-on-one after each workshop, and this is where we can tailor what at the fall regional workshops that we talked about for the comprehensive track. So this is intended to meet providers where they and their communities are. So we know different communities have different ability to access data, as well as different abilities to interpret it or collect additional data. So we will talk one-on-one with you after seeing your prioritized consumption and consequence data. We will try to go deep with you to see if you can collect additional data, how you can do that most practically. So in this, we're thinking about helping you figure out what investment of time is going to get you the most bang for your buck in terms of data collection. We know it's, in some communities, and very, very lucky communities, it's really easy to do a youth survey, but there's a whole lot of places where that's not easy. And so we'll talk with you about the realities of your communities and where things are practical and where things are not. And then we, as mentioned, we recognize that we know that some places can collect local data, and some really aren't in that position where they can do it. And per state guidance, that is acceptable if all you can use is what you have been given from us at the first workshop. That's fine. We'll work with that in helping ask you questions to help you get to the best, most meaningful result for your needs assessment. But if you can do a little bit of data collection, we'll help you with that too, to help you figure out where you can do that most meaningfully. It will, of course, this will be most effective, these sessions, for you if you can submit your prioritized data ahead, as well as your list of intervening variable data after the first workshop. We are not expecting after the first workshop for you to have done anything with prioritizing and intervening variable data, only in trying to prioritize your consumption and consequence data. And again, we do expect that consumption and consequence data is really just going to be a few key measures, just enough to help you know you're in the right direction, but not everything that could possibly be available. And that's strategically intended. We know very often those indicators point in the same direction, those multiple indicators, and sometimes it can be very overwhelming. So we've decided to recommend just a few consumption and consequence measures for each commonly abused substance. And we're going to spend a lot more of our time on the intervening variables to really focus on choosing the right intervening variables for our communities, which will tie into the most effective strategies for our communities as well. Bill, do you want to add anything into that?
And just that I think that what Melinda was just speaking to everybody probably is the key, right, to what we're trying to address. The most important part of effective prevention is the pursuit of strategies. And so what we like to, as an evaluator, I always tell people that it's not about getting all the data, it's about getting just enough data that within the realm of probability allows you to plan your strategies, right? So it's not, there's no contest for whoever gets the most data wins. In fact, it's the opposite, because for every minute that you're pursuing other types of data, that's a minute that you could be strategically planning. And I think that's the real key of the one-on-one. There's no fancy homework assignment. I think just being able to see where you are and have a conversation with you about where you want to go, and then helping you build a plan from there. So yeah, I think that's really key to what we're trying to do.
Thank you. And we can go to the next slide. One of the concerns that we had with the last assessment workshops is the template that we had was challenging for providers to use, and it also disconnected the consumption and consequence data from the intervening variable data. This template will be built in Word, and it will be designed to help providers look at one step in the assessment process and move to another, and to be able to see that so you can really kind of really follow how you're making decisions. So when you look back, you'll be able to say, oh, I decided to focus on retail access to tobacco because I had these really high youth tobacco rates in my community. We knew we had a very, very high sales rate of youth to minor. We saw why that was happening in our community, and so forth. And so it will be designed to help you see kind of one step from another how this process builds to create that comprehensive strategy at the end.
If I could just add something to that too, is I think it's finding a way to report out on the information that allows the provider or the coalition to be much more specific about what the projected impact of each intervention type is. So when we're thinking about, for example, doing different interventions, sometimes, and I know that there's a lot of trainers and methods of training, certainly that I've been exposed to in the variety of models that I've seen, that it can be easily digested as a checklist, right? So when we're thinking about the 6 different things, right, the intervention types, and we have often providers or coalitions will go, okay, so we're doing this, check, we're doing that, check. What is more useful, I think, is allowing someone to more easily keep track of how those are aligned. And so I think that's the primary difference, is that when you're trying to provide information to community groups or to potential partners, you'll be able to show them a document that is more self-explanatory in terms of, if we check the box of providing information, we're also going to make sure that whoever's looking at that document understands what kind of information we're providing and how that fits into our overall strategy, as opposed to just seeing that we're providing information.
Thank you, Bill. And yes, thank you. And for the next thing, I just wanted to take a couple of minutes to talk about the dashboards and show them. We do not have any homework from this section, although you might find it valuable to look for how your communities look on the alcohol and the public health and the NC Opioid Action Plan Data Dashboard. We do have those dashboard links provided, and we can include that in a follow-up email as well. But Bill, do you want to click on the alcohol dashboard? And then scroll on the dashboard to the right. Go past the consumption. You see the header, alcohol and the public health in North Carolina. Scroll more right. There's a lot of background which is useful to look at, but what I'm scrolling to is there is a county health profile for everyone, including there's some cost data, which could be very meaningful for your policymakers. Yeah, go ahead and blow this page up so we can show folks. So you can see at a glance that the alcohol-related deaths are very high in, I can't see what that almost coastal county is. I think that's in CPS's territory, Jones County. Well, maybe that's in Power of U's territory. And the alcohol-related deaths, there's some very high ones in the mountains to the right, as well as in northeastern North Carolina. So we have alcohol-related deaths, emergency department visits, and if you scroll down a little bit more, Bill, you can see this is right now queued up for Alamance County, but it shows the trends of alcohol-related deaths. It shows alcohol-involved crashes. These are done, you can see, in 5-year intervals. So you might not have as much trend data for some measures where there's infrequent occurrences as others, but we'll have some data for that. It also shows, if you look down at the health data, so it shows deaths in rates and counts. And for the data that we supply you, we will supply both, and we'll talk about when you use which one and why. Then for the ED visits, it also supplies rates and counts, but it includes a under 21 count, so that might be especially meaningful for some who really want to focus on underage alcohol use. It shows the economic costs. So in Alamance County, which is not a large county, it's $111 million. So that number might be very striking for your policymakers, how much alcohol is costing you. And it also does have outlet data, so you know how many outlets you have. So that's an example of what you can get in the alcohol dashboard. It's not required, but I do encourage you to look at that just to get a sense of how that data looks for your counties. And again, we have this web address in the slides, and we will have Jamie also send that out with the notification of when the webinar is available online. If that's all right, Jamie. And then, Bill, can you also, now could you click on the opioid action plan data?
Sure.
And then go down to the metric summary table. It's in the left-hand column. You'll be able to click on it. Go up much higher. Oh, you passed it. Go all the way up.
Sorry. Oh,
that's fine. So the summary table. So the summary table shows which measures that we have available. This is at the state level, but you can ask for it at the county level. But so you can get data up to the most recent quarter. Depending upon that measure, that lags 3 to 6 months typically. But so you do get some death data, some emergency department data for overdoses. You have some measures available for that related to prescribing, as well as it has data on what percentage of your deaths in your community are due to heroin and fentanyl versus prescription, a naloxone treatment, as well as treatment and recovery. So, and then Bill, again, scroll up again and just to show a map view of the data. Go to reduce oversupply. So if you look at these data, they will show, this again can show the county or the state. So you can look at all of these. So you'll see a map with the most recent county. So you see where the highest event of multiple provider episodes are. And multiple provider events are when a provider is seeing multiple prescribers and multiple pharmacies to get medication. And you can also see in that map the trends. So you can see since about 2010, the number of multiple provider events has been decreasing. And so there'll be these maps for all of those 10 indicators the dashboard is tracking for every county. So you'll be able to see the trend as well as the map. So it's really easy to tell at a glance with this dashboard how your county looks. So I do encourage you to spend a little bit of time on this, but don't worry about writing it down or getting into a data file or anything. We will supply the most up-to-date data for you for this. So you don't have to get it. It's just to get a sense before we meet again on how your communities look. And this obviously will be a view just for alcohol and prescription drugs, but these websites are very easily accessible. They're very visual, so it's really easy to look at a glance how things look in your communities. So we encourage you to do that. And then finally, and we'll send this dashboard address for those who are not familiar with it. Then we want to just close to your questions.
Melinda, we do have several questions.
Okay.
Related to NC Detect data.
Yes.
When will providers have access to NC Detect data?
Providers won't have direct access to NC Detect data, but we will provide a data file with NC Detect data at Workshop 1. And so we don't yet have it, but we are expecting to have it very soon. Providers who have a good relationship with in their health department can get that. Health departments can supply anytime if you have a relationship where they're willing to do that, but we'll supply it at Workshop 1.
Okay. We have another question in terms of PowerPoint slides and addresses, web addresses. We'll make sure that everybody has copies of the slides, and actually we will create a traditional article on the help desk that includes the slides and the video of the webinar. We do have a lot of excitement about the data, Melinda, so that's wonderful. We do have some other questions. For example, in the administrative and archive data review, if that data is indicating one thing, for example, a store was compliant in a particular instance, but community surveys show other data points that's somewhat contradictory in nature. would there be a way to show both data sets during the assessment process to evaluate maybe the local contradictions that folks are seeing versus what the data is saying, archive data?
Do you want to address that?
Yeah, sorry. I have to unmute. Sorry. Oh, I am unmuted. Okay. So yeah, I think that that's really important. I think that's primarily where the one-on-one information comes from, and I don't. So some of this is based on the kind of contradiction that there is, and so what I would say about that is, in general, I think it's more important to have conversations about why you ended up where you are with the current strategy. If, however, there's a contradiction that might hinder, or there's a contradiction that would that we should keep an eye out for later in the process, right? Then I think that's the point of having that conversation. And yes, we can come up with ways to track that information, because I think it's critically important, particularly in the assessment process. If the assessment is going to be an ongoing document, not only does it need to track the kinds of data that is not contradictory, we're building a case, but I think it's also important to talk about in general the kinds of contradictions that can come up or that have come up, and how we think that might be impacting what we're doing next. So I think that tracking those kinds of things, but I would be careful, and you may notice some hesitation in my voice, I'd be careful to say that we want to manage, sorry, that's my cat begging for food, that we want to make sure that we're only including that kind of information that's going to allow us to continue to use the assessment as an ongoing process, as opposed to pointing out, for example, every contradiction in the data. Because part of what we're going to, and I actually never been a part of an evaluation project or a community project where there is not some contradiction, right? That you're always going to have data sources that seem to, at some level, maybe even if it's just not supporting each other or slightly contradict. I think the point is being very careful about which types of data we're going to use and which types of contradictions we think may hinder us. So the very long-winded answer to that is going to be yes, and part of that is going to be our ability to filter what we're going to actually record based on the kind of contradiction that's there and how we think it may be impacting our future.
Thank you, Bill. If we have, and the audience may have follow-up questions related to this particular point, which is a great point, we can certainly revisit. Melinda, this could be another question for you. What's the role of LME MCOs in this process? What is their level of responsibility, and how can they provide support to prevention staff in the community?
Good question. I think that might be one that we might have to provide a little bit of follow-up on, but at a baseline, providers, of course, have to submit their assessments to the LME MCO to get submitted to the state. LME MCOs are, of course, responsible for ensuring they get done. They probably do want to check that they've been done comprehensively and that they've really applied the principles that we will be talking about, particularly alignment and prioritization. But that is a question I do want to give a little bit more thought to. But at a base, of course, they have to collect and approve those assessments for providers.
Thank you, Melinda. Does anyone have other questions or points of concern that we need to address this morning? Melinda and Bill, while those final questions come in, do you have any final thoughts and other items that we need to address?
I would just like to share that it is our hope that by the end of this process that providers do, of course, feel supported in completing it. But most importantly, our goal is that this is really a meaningful process for your community, that you do not leave feeling like you've just checked off boxes, but that this is really setting you on the path to make good decisions for your FY 2020 strategic plan. That is our primary goal, and we do of course encourage you to ask us questions along the way to help ensure that we meet that goal.
Yeah, thanks, Melinda. And I think I would just add that I've been a part on both ends of these kinds of things, being a former coordinator of a few different coalitions. And I just want to assure everyone, in case there are people who are going, oh no, now we have to go do this other stuff, that's not what this is about. I mean, we're very careful in saying that the work that you've done up to this point and how you've done that work is important and significant in your communities. And that's not just lip service, it very much is. And that what we're trying to do is to build on what you've already done and what you already know, so that you can be, even if it's just slightly, more effective in what we're doing. And I think we're all concerned with effectiveness. And I think, like anything else, we have to take lessons learned in the reality of doing our work to figure out sometimes what it is that we can improve on. And I think that that's the goal here. The goal is to just take the lessons learned, that we're not blowing anything up and starting from scratch in any way at all. That it's just it's trying to make the processes that you're already engaged in, looking at those processes in a way that hopefully will make you more efficient, so that you can spend your resources more wisely on the actual action of what communities should be doing. So I just wanted to emphasize that.
Thank you, Bill. That's excellent points to make for our providers. As all of you, if not most of you, if not all of you know, we certainly have went through this process before. We did look very carefully at the last assessments, and we know there's a whole lot we did really, really well with those. I don't know if you guys have heard that, but there is. And but at those places where they were not quite as strong, those are the places where we built in more individualized feedback. So we are definitely building on what you've already done and done very, very well, and just trying to provide a little extra support where things are more challenging and where you probably have questions that you like to address, both with us and with your communities. And so we hope this is not going to be a scary process, but one that you really feel like is a really good investment of your time and efforts, and that you leave the end of it feeling good about what you've done and where it's leading you.
Thank you. It's 11:25, so we have hit the timeline that we had hoped. Again, I do not see any new questions. Although, Melinda, we do have a question that just popped through in terms of the general timeline for the needs assessment process. and when the final work should be completed and submitted to the state in terms of the work product?
Yeah, so we have designed this process so each step kind of builds upon each other. So after the first workshop, we'll have done the prioritizing the problems in our community. So that's going to be really focused on the consumption and consequence. We'll be have the intervening variable data but we won't have started to use it. At the second workshop in mid-April, that's when we will start working on prioritizing that data. But we're gonna have it slowly build and provide feedback along the way to help that go smoothly. But so at midpoint check-in 1, you will submit your consumption and consequence priorities, as well as the list of the intervening variable data that you do have, and we'll provide more instruction with that obviously at workshop 1. Workshop 2 is where we'll start working on that in the hands-on work of that workshop. And then at midpoint check-in 2, which is going to happen 2 weeks later, so that'll happen at the beginning of May. That's when we'll review what you guys have and help set you on the path to be able to submit that at the end of June.
Okay.
So we'll have it broken down in steps and have feedback after the key steps to help you be ready to submit that.
Okay. Let me check the Q&A box. So the needs assessment being due by the end of June.
Yeah, you will submit that with your fiscal year 2020 compliance report. So every LME, of course, has their own due date for providers for that. They're often around the 10th of July. But for practical purposes, you're going to have it ready about the end of June, early July.
Okay. Let's see. We'll give folks just a few more minutes to populate questions. But in the meantime, the slide deck for today's presentation is actually already online within the help desk. There's a new article posted for this event that posted a few minutes ago. We will add the video in coming days with a direct link so you can access all those resources. Also, Melinda mentioned the face-to-face trainings in Winston-Salem and Raleigh. We will, those items are on the calendar, the TTA calendar, but registration is not active yet. We will activate those registration links and email everybody before Christmas to allow for registration. And we will be setting up as normal, a state rate hotel block for attendees who may have to stay overnight, who are not close to Winston-Salem or the Raleigh location. I do not see, let's see, last question. Do LME MCO staff, can they attend the workshops or need to attend the workshops, Melinda?
They certainly can, and I believe it would be encouraged for them to attend to understand those expectations of their providers.
Okay. Of course, LME and MCO staff will receive a link to the registration process as well. Okay. Any last words before we close up shop? Okay. Again, thank you for logging in today, this Monday after Thanksgiving. And about 60 minutes after we end the webinar, you will receive an automated email that will include 2 items, a certificate for your records, and the second item is a survey we ask everybody to fill out the survey. It will take you less than 3 minutes, and it will help us design the face-to-face events and better communicate really important points that we may have left out. And Melinda?
I just want to add, I just got a text from Jessica. She said that providers do not have to send the needs assessment in. They will upload it to the briefcase in Echo, and LME MCOs can approve it from the briefcase in Echo.
Okay, good message. Okay, we're in the last review of our Q&A box, which is empty. So again, thank you so much for logging in today, and take care.